welcome to Lynchburg Live. I'm your host, Linda Smith. My guest tonight is Dr. Thomas Carrico, Medical Director of Centra Health Center for Wound Care and Hyperbaric Medicine. One of the most interesting things that I think advances in wound care is hyperbaric therapy. Dr. Carrico is going to be telling us about that tonight. Welcome to Lynchburg Live.
Well, thank you. Thank you for having me on.
Delighted to have you. As Medical Director of Centra's Center for Wound Care and Hyperbaric Medicine, please tell me what that is. What do you do?
What do I do? That's a good question. Well, I'm the medical director for the center, and the center is a specialized center for management of difficult wounds, people that are having difficult times healing either a leg ulcer or a surgical wound or a traumatic injury or whatever. And we have multiple treatment options available to us, including hyperbaric oxygen therapy.
That's great. I'm really interested in that. Where are you located?
We're strategically located on the second floor at Virginia Baptist Hospital. It's a very nice site because we're very close to the radiology suite, as well as the laboratory, as well as physical therapy, are all within 3 or 4 steps of our center, and we work very well with all those other specialties for our patients. The parking is available at the hospital parking lot, so it's a convenient and location for us.
And once you get into the hospital, this is the door you're looking for, the one that's behind us.
And it's actually, as you get off the elevator on the second floor, you are looking right at the center.
At that door. What are the types of wounds that you care for?
We see a lot of different types of wounds, but probably the majority of the wounds, and the reason we opened the center in the first place is for people with diabetic ulcers. People, as you know, that have diabetes often have some problems with blood flow to their lower extremities, to their legs and feet. They can have problems with the big blood vessels that deliver the blood down the leg. That's peripheral arterial disease. And they can also have small vessel disease, where the diabetes actually affects the very small blood vessels in the skin, so that these wounds that the patient get on their feet just won't heal. They get these ulcers a lot of times because they lose the feeling in their feet. It's called diabetic neuropathy. So very often the patient has an ulcer before they even know that they're having a problem, and they've had a bad ulcer before they even realize that something's happened to their foot. We also treat patients that have venous insufficiency, where the blood return from the lower extremity is impaired from previous blood clots or phlebitis, and they develop swelling and irritation of the skin, and then that can develop into ulcers that are very difficult to heal. We have patients that are on different types of medication that impair their healing. We have patients that have had radiation therapy for cancer that may have a difficult time healing in the area where they've had radiation therapy. So it's a broad spectrum of different challenging problems that we see.
For people who may not know, how prevalent are these chronic non-healing wounds?
It's hard to say exactly, but I can tell you by our patient load and the waiting list that it's a lot. It's more common than you think, and I think having a center that specializes in treating these ulcers is it's a tribute to Centra that they've invested in really a state-of-the-art center. We have a lot of diabetics in the Central Virginia area, more than you would expect based on our population numbers. It's a higher incidence of diabetes, therefore we have a higher incidence of these ulcers. But it's a very prevalent problem, and we're very glad to be here to help these folks out.
And diabetes is the main cause for these wounds?
About 3/4 of our patients have diabetes. Yes, ma'am.
Now, do you care for the patients who are hospitalized, or do you see them on an outpatient basis as well?
Our center is an outpatient center. We have a team of specialized nurses that are certified wound ostomy nurses that are excellent. I've been around the country. I've never seen any better. But we have 3 of those nurses that see our inpatients. We actually have put in you'd be interested in this, having a medical background, but we've put in an ulcer prevention program throughout Centra Health, where any new patient is evaluated for their risks of developing an ulcer while they're hospitalized. If they're rated on a scale called a Braden scale, and if they score a certain number or lower, automatically they're placed on a low-pressure bed. They're seen by our wound care nurse team, et cetera. Now, if they have a patient that needs more involved care, such as debridement or surgical cleaning up of the ulcer, or if they need hyperbaric therapy, that's when they would call me, and I would go see them in the hospital. But most of the patients I see are outpatients and follow-ups from the hospital.
And they're referred to you by surgeons and...
Right. We get referrals from every specialty you can imagine. A lot from primary care physicians, a lot from surgeons, a lot from our orthopedic surgeon colleagues, many from the radiation therapists.
I know that your wound care is directed toward an individual patient.
Right.
But what types of individual care do you give? I'm not doing this very well, but what I'm trying to say is, on the broad spectrum, the different types of treatment.
How do we figure out what to do with what patient?
Yeah.
That's a good question.
Thank you for pulling me out of that one.
Well, that's our first visit is a very lengthy visit because we do a lot of assessments on the patient. And that includes a nutritional assessment. We look at all the medications that the patients are on and see what a lot of medications will impair healing one way or the other. We do a vascular assessment on if the wound's on the lower extremity, take a thorough medical history and physical exam, and basically in that first visit identify what is the impairment to the healing. Right. And a lot of times it's a combination of things. You can have a diabetic that has some peripheral vascular disease that also has venous insufficiency and maybe on a couple of different medications that impairs their healing as well. So it may be a multifactorial problem as to why this wound won't heal. But the first step, the first visit, is usually to identify where's the defect, why isn't this wound healing. Most of the people that have come to us have failed to heal with standard therapy at their primary physician or their surgeon's office. Once we identify what we think the main problems are with the healing, well, then we design a care plan that addresses those specific issues. If it's a venous insufficiency problem with edema, we'll start with a reduction of that swelling, a reduction of that edema. If it's a vascular problem, we can't feel their pulses in their feet or what have you, we'll get the proper testing done and get them to the vascular surgeons or the cardiologist to improve that blood flow to their foot. Whatever we define the defect, we do what it takes to work around that defect so the patient has a better opportunity to heal.
So it's really an interdisciplinary.
We do. We rely a lot on our colleagues, our vascular surgeons, our cardiologists, radiologists.
Diet therapy, too.
We use the dietitians quite a bit, diabetic educators,
right.
Physical therapy. We use a lot of different consultants. But again, we tend to be the hub of the wheel, if you will, and we'll identify the problem and then utilize whatever specialists we need to maximize the chances that the patient's going to improve or heal their wound.
I wanted to pay particular attention to hyperbaric therapy because
Sure.
I think that's so interesting, and I know that a lot of our audience probably is not that familiar with it. But if you say hyperbaric therapy, a lot of people, the first thing they're going to think about is Michael Jackson and the rumor that he was sleeping in a hyperbaric
Right.
chamber to maintain youth.
And the athletes these days that use the hyperbaric chamber to speed healing from their athletic injuries. A few years ago, Terrell Owens had a fracture, I think it was 4 weeks before the Super Bowl, and with the aid of hyperbaric therapy was able to play in the Super Bowl and catch 11 passes. So the hyperbaric therapy does get a lot of publicity. Hyperbaric oxygen therapy is a very specific therapy. There are risks involved, just like any other medical therapy.
Right.
And we go make sure the patient's completely informed about all of that as well. But there's no question that it facilitates healing. There are specific indications for it. We are very strict in our criterion for using the hyperbaric therapy. We follow the Medicare guidelines. There's 13 approved diagnoses for the use of hyperbaric therapy, and we treat those 13 diagnoses. The reason those are approved is because there's data. There's good information out there that hyperbaric therapy actually will improve the situation. There's a lot of other reasons that people use hyperbaric therapy such as Michael Jackson, the anti-aging, and all these kind of things, where there really is not data to support the use of it. And so we do not treat these so-called off-label diagnoses. We adhere to the guidelines set out by Medicare.
I think you had mentioned to me that people were experimenting with it with autism and irritable bowel syndrome,
right.
And a number of things.
There are anecdotal reports of it being effective for, and we get calls every day for people that are having problems that aren't on that list of the 13 approved diagnoses, and we've just made a decision that we will treat the ones where there's data to support the use of it, and we're not going to treat the ones where we don't have any proof. But there certainly are anecdotal reports for other disease entities that are encouraging, and there's research every day. And every once in a while there's a new indication approved by Medicare. And so there's some really exciting potential uses for hyperbaric therapy on the horizon, but they're not, the data is still evolving.
You know, as I was coming along as a student nurse, there were only like 2 hyperbaric units in the state of Virginia. How many do we have now at Virginia Baptist Hospital?
Well, we have 2 what we call monoplace chambers. In terms of how many units in the, how many hyperbaric centers are there in the Commonwealth right now, I would say probably a dozen or less. There is an accreditation process for these centers through the Undersea and Hyperbaric Medical Society, which is a small group of people that actually started with the military applications of hyperbaric therapy for the bends. At any rate, that has evolved, and that is our governing body now, and they have an accreditation process. It's very, very stringent, and it's really dedicated to patient safety. I'm happy to say that we were just approved for another 3 years. This is our 3rd go-round of being accredited. There are less than 100, there's actually 99 accredited facilities in the world. We happen to be one of 4 in the Commonwealth of Virginia that are accredited by the UHMS. So we're very proud of that. It's a statement regarding Centra and their commitment to excellence and their commitment to really having a very safe environment for our patients.
You know, Centra has done so much to bring a lot of innovations to Lynchburg, and I think we're very fortunate to have that. Are there different size units, hyperbaric units?
There are, basically there's 2 types of hyperbaric chambers. There's a monoplace chamber, which is 1 patient at a time gets in the chamber. It's a small tube. We'll have some pictures in a second. We'll show the ones that we have. And then there's what's called a multiplace chamber, which is where up to a dozen patients can get in. It's basically a room-sized chamber.
I can't imagine.
And but they're pretty interesting. They look like little submarines. But at any rate, those tend to be in either big research centers. The Mayo Clinic just opened a 16-bed multiplace chamber, or in military establishments. So the community hospitals that have hyperbaric chambers, the majority of them are monoplace chambers, like what we have here at Centra.
We're going to look at the pictures in just a second, but I want to ask you one more thing. Which conditions respond most favorably to hyperbaric therapy?
Well, I don't want to answer that in too long-winded a way, but it helps to understand a little bit what it does. Hyperbaric oxygen therapy, the patient is actually totally in the chamber. And we'll see a picture of a patient in the chamber in a second. They breathe 100% oxygen. Right now, you and I are breathing 20% oxygen. And then we increase the pressure within the chamber. Right now, we're sitting under 1 atmosphere of pressure, which is the weight of the air from sea level to space. We raise the pressure in the chamber to 2 atmospheres of pressure, which is if you're a scuba diver, it would be equivalent to going to about a 50-foot scuba dive, which is not a deep dive. Patient really doesn't feel any pressure other than their ears might pop like you would driving up and down on the parkway. What that does, when the patient's in that environment, breathing 100% oxygen at 2 atmospheres of pressure, they absorb oxygen through their lungs, and the circulating oxygen in their body is about 15 times what it is for you and I right now under normal conditions. And what that does for a wound that's not healing, particularly in our diabetic patients or in our radiation patients that have that small vessel problem, and we talked about diabetes having a propensity to injure those small vessels in the skin, it actually encourages new blood vessel growth in that area. It also speeds up the metabolism, so it speeds up the fibroblasts, which are making scar tissue, makes white blood cells that fight infection, makes them work better and faster. It enhances certain antibiotics so that antibiotics will work more effectively to kill the bacteria. And the last thing is it actually gets into bone at a higher level than the antibiotics will get into the bone. So, and in that capacity, it's bactericidal. It kills bacteria just like an antibiotic will. So it's like another antibiotic, if you want to think of it that way. So to get back to your question, what is it best used for is for the patients that have small vessel problems, or diabetics, patients who have had radiation therapy, patients have bone infection or osteomyelitis, again, which can be our diabetics. They could have a foot ulcer, like I said, before they even know it's there. It could be down involving the bone, deep structures. It gets in there, fights infection, promotes vessel growth, promotes healing, get these things healed up. And it has a long-term benefit in it with the buildup of those blood vessels that will help prevent having problems in the future after they've had the treatment.
You've brought some pictures, Phil. If you'll put them up on the screen, we'll get Dr. Carrico to tell us what they are.
This is at one of our monoplace chambers at Baptist, and this is our technician to the right there, Randy Tucker. He and I are the only employees that have been with the center the whole, this is beginning our 9th year. That patient is in the chamber right now. The head is towards us, so you can't really see who it is, whatever. But you can't be completely sitting up, but you can get comfortable in there. Most people watch the television or just take a nap while they're in the chamber. They're in the chamber for a little over 90 minutes. It's 90 minutes at depth, in other words, at 2 atmospheres. And it takes about 8 minutes to get them to the 2 atmospheres of pressure, and it takes about 8 minutes to get them out of the pressure. So they're in there a little over 90 minutes. The typical treatment is about 4 to 6 weeks, so 30 to 40 treatments. Again, that's Randy. We communicate with the patient. We have a little two-way handset there that we can talk to the patient if there's any problems. There's always a physician on site. Usually that's me. But at any rate, there's always a physician there should a problem arise during the treatment. We can get the patient out and take care of whatever the problem is. There's the 2 chambers that we have sort of side by side. There is a curtain that goes between them, so there can be some privacy, etc. But you can see it's a big acrylic tube. It's a little different from an MRI machine. You can see out. People do have issues with claustrophobia and feeling confined. But usually after the first treatment, most of that fear is gone. They realize it's not that bad, and most people say if they don't touch the side of the chamber, they don't feel like they're enclosed at all. So it's not like an MRI where you get that.
And you really can't see with an MRI.
Right. You're looking at the wall of the MRI machine. That's me, the medical director there with the chambers. We actually have DVDs hooked up to the TV, so people can bring movies in.
Oh, that's wonderful.
And watch a movie while they're in the chamber.
And you had said to me, and of course I knew this, but you have to wear nothing but cotton clothing.
Right. Because of the 100% oxygen environment, you have to have 100%. You have to have cotton clothing, so you have to change. This is a little ultrasonic debridement system that we just purchased. We just put it into place about 3 months ago. It's almost a painless way to clean up these wounds or debride these chronic wounds. It works with ultrasound and saline in combination, and we've had some really dramatic results in improving the rate of healing, especially on venous ulcers. We're really happy with that setup. That's a little, and that can roll from room to room. We only have one. We'd like to get one over at the other hospital at some point. But, and this is a compression system that we use for vein disease, for patients that have a lot of swelling in their leg and have these venous ulcers that can be very difficult to get to heal. It's put on, it's a 4-layer, almost like a soft cast. You can see that layer with a little yellow stripe is put on in a figure of 8 fashion that mimics the way your muscles work in your leg to pump the blood back out of your leg and get rid of the swelling. We can really dramatically decrease the swelling. And there's a lot of studies that show that you reduce the swelling and improves the oxygenation to the skin, and these wounds just heal so much faster. We do have to make sure the patient has good arterial inflow. However, you don't want to put a tight bandage on somebody that has compromised their inflow. But these work very effectively, sort of in place of the old Una boots or the old Una paste boots that they've been used for years. These are more comfortable. They allow for a little swelling if the patient's up and about more. And they do a terrific job of reducing the swelling in the lower extremities. And this shows the final bandage. We change this once a week. So the patient comes in once a week and we change the bandage. We can use different types of bandages. And this is just a slide I use in talks I give to other medical folks just to show people that there's so many choices now in different wound care bandages or dressings. And we use wet dressings and dry dressings and silver dressings and colloids and
I was going to ask
alginates, and all these different types of dressings. And how do you know which one to use on which wound?
If you still do wet to dry dressings?
We do not do wet to dry dressings. Of course, it was the old standby
Right.
for years and years. And the purpose of that was to debride or to take that dead tissue off. You'd put a wet dressing on wet, you'd pull it off, it would hurt. Sometimes it would bleed. But we can do that with that ultrasound debridement that we showed. We can do that in 10 minutes rather than weeks and weeks and weeks of wet to dry dressings. We really, science has shown that a moist wound environment is much better for the skin cells to rapidly go across an ulcer rather than letting the wound dry out. We don't use things like betadine, iodine, some of those things that were used when I was coming along, when you were coming along. We used all the time on wounds. We don't do that at all anymore. This is a machine called a transcutaneous oxygen measurement, or a TCOM. It's one of our nurses, and we can put little electrodes, almost like EKG electrodes, up and down the extremity, and we can actually map the oxygenation. This really is very helpful in our diabetic patients, and we can show that the environment around an ulcer or a wound. This patient had a wound on his foot, on his toe, actually, his big toe, and we can show that the oxygenation is decreased, even though they may have pretty good inflow. They may have that small vessel disease that we talked about, and this machine will identify that. We can also use this to try to identify patients who would be good candidates for hyperbaric oxygen therapy. The last part of the test, a patient wears an oxygen mask, and these numbers you see on the console, this would show that the normal being up around 110 to get down to the patient's foot, and it's down to 23. Well, we know that it's very unlikely the wound's going to heal at less than 40. So that patient, we'd try to put the mask on. If these numbers triple, then you would expect them to be a good candidate to respond to hyperbaric oxygen therapy. So it's used for diagnostics, to recognize these wounds that are not getting enough oxygen, but then we can also use it as a tool to tell us which patients are actually going to be good candidates for hyperbaric oxygen therapy.
How effective is hyperbaric therapy against these superbugs that we hear so much about? I mean, there's MRSA and
the antibiotic resistant bacteria. It's good against it doesn't particularly work better against them than any other bacteria. There actually are, like our silver dressings actually work very well against MRSA. There's a couple ointments that we use that are very effective against the antibiotic resistant bacteria. The hyperbaric oxygen therapy itself is very effective. There's certain bacteria like Clostridia, you may remember that from the old gas gangrene from the old days, but we don't see much of that anymore. But it specifically negates the toxins that are produced by that particular bacteria. It doesn't really have any specific effect against MRSA or VRE or any of these other particular bacteria, other than what we already talked about. It's enhanced the function of the white blood cells. It enhances the function of the antibiotics that the patient's already getting. So it has effects, sort of secondary effects, but in terms of working against that specific bacteria, it's not really useful.
How about burns?
It's not really used for burns. But again, if you think about what's happening with a burn injury, it's not really a vascular issue. It's not really an oxygenation problem. So it's not really used that much for burns. And some of the bigger centers, the burn centers, it can be used if you have patients that are either 3 depths of burns, and if you want to, the 3rd degree burn being worse than the 2nd degree burn in terms of its depth into the skin. And sometimes people will come in with different levels, and some people will treat a burn with hyperbaric therapy to try to limit how much 3rd degree burn there is. But that's a very short-term thing early on in the injury, and we really don't treat a lot of serious burns here in Lynchburg. Most of those are sent to the university's burn centers.
Is this the same chamber that people who have the bends?
Well,
is it similar?
They're very similar. The only difference really is that these chambers, the maximum pressure that we can achieve is 3 atmospheres, and that's plenty for all of those 13 indications that I talked about earlier: the wound healing problems, the carbon monoxide poisoning, the radiation injury from radiation therapy. The military chambers are used to treat the bends, which is when a diver goes deep into the water and then comes up too quickly, the air will form bubbles in the blood. And what they use those chambers is to put the patient back to the depth that they were, where they were, and then bring them up very slowly. And those chambers will go to 6-7 atmospheres. Ours go to a maximum of 3 atmospheres. But basically the same technology.
I thought it might, help the audience sort of
We've had one diving call in 8 years, and that was a patient that had been in Barbados and had had a deep diving course, waited 2 or 3 days to fly back to Lynchburg and had some arm pain. And, it was not really the bends. I think their luggage was too heavy and they strained their shoulder.
Now, you and all of your staff are specially trained in hyperbaric therapy.
I am, and then we have 2 physicians, Dr. Dunstan, Dr. Lefke, fill in for me. They've been to a lengthy course. We have Randy, our hyperbaric technician. You saw photos of him. We also have a certified hyperbaric nurse, Cheryl Sale, who's our clinical coordinator. And our other nurses are all wound specialized and have some special training in wound care. And they understand the hyperbaric emergency. So if they're called to be involved in something, they certainly know what to do with that. But they don't manage the day-to-day hyperbaric patients. Right. It's myself and Randy or Cheryl. And then, of course, we have the wound ostomy nurses on the inpatient side.
As hard as it is to believe, we only have about 2 more minutes.
Oh, my goodness.
So I want to ask you, is there a website that the audience can go to if they're interested in finding out more about hyperbaric therapy?
The best website, if you're really interested in learning more about this, is the Undersea and Hyperbaric Medical Society website. That's our international organizing body, and they have a section that is for folks like myself that provide this care, but there's plenty of information there for the general public, and that is www.uhms.org. It's really easy if you know it, but it's uhms.org. Has anything you'd ever want to know about hyperbaric medicine.
I was going to ask you very quickly, what's a dermograft?
A dermograft, or an aplograft, we actually use more often now, is an allogenic skin substitute. What the aplograft, we are getting lots of tremendous results with. It's a biologically active dressing. It's actually human skin cells that are grown in tissue culture that we can place on a wound. It releases a compound called growth factors, which is a protein that stimulates the wound to heal. And we use them a lot. They're very, very good at really kind of, well, I tell the patients, like jump-starting the wound, getting it going.
You know, that's so interesting. That's a whole nother show.
It could be. It could be.
I want to thank you so much for coming on and telling us about this and letting my audience know that this is available here in Lynchburg.
Well, it's a pleasure to be here. Thanks for having me.
Thank you so much. I hope you've enjoyed tonight's show. My next show will feature the crisis line of Central Virginia. Thank you so much for watching. Have a wonderful evening. Good night.